I'll sort of, we can see on there.
So I'll let the members of the panel introduce themselves when we have moved on from audience questions. But what we were going to do first is get audience questions or comments, insights that you might have as the health consumer representatives, patient advocates, having worked with patient advocates in research, maybe in health communication research or otherwise, or any questions that you might have for someone like Jen or Darlene, who is the CEO of the Health Consumer Care Association in the ACT, or Rebekah Ogilvie, who is a nurse of the year in the ACT and has also extensively worked with patients, not just in a clinical capacity. So are there any questions in the room to get us started? Sure.
Hi, and thank you so much for that talk, because I'm sitting there going, oh, yeah, I have the same sort of income. I've had a lot of war experiences with different specialists for very similar reasons, but I've also had some really good ones. And my question is, how and sort of what should we expect from clinicians teaching other clinicians? Because everyone in this room is, I hope, very interested in better communication, but it's people outside of this room that are the problem. So what's their observations? What do you think that would look like?
Thank you, Steve. Very good question. And I mean, there's 1,001 answers to that, so I'll just focus on the bit that I've spoken about around, I think one of the most important and powerful things that anyone either explicitly teaching, somebody or just being a senior or more experienced person around them can do is model the I don't know. My goodness, would that make a difference, right? Because we heard earlier today, people who work with medical students saying, oh, not that hesitant on it early on, but somewhere they pick that up, right? And I think modeling it about themselves for a senior person in front of a patient, in front of a junior person, in front of a whole bunch of people to say, you know what, I don't know, but here's what I'm going to do about the fact that I don't know. I'm going to go look that up, or I'm going to refer you to this person, or be practical about it. But those 3 words alone, coming out of a senior person now in front of a junior, or a training person is really big. And I think the other thing, that people need to do is stop sometimes using this language or just this general vibe, thinking of communication and talking about communication as a soft skill, right? It is a life and death skill, and people need to talk about it that way. And we've seen the stuff today. I don't need to go over that with everyone here about how much it is a life and death skill, and really flipping that on its head and saying, let's start with communication, then let's do biology later. Medical school does it the other way around, and you can do the same thing. But the way we choose to order the curriculum teaches priorities, right? And I think that we need to rethink some of that work as well. And modelling non-scripting behaviours. Like I said, all my practitioners are non-scripters, that's why I use them. And being able to model just like working with it as it comes, is actually really, really important. So I want to add anything?
Yeah, hi, Darlene Cox from Healthcare Consumers Association. Thanks, Jen. I just want to acknowledge we're on Ngunnawal land and pay my respects to elders, past, present, and emerging leaders. Couple of things to add to that. We spend a lot of time at Healthcare Consumers working with consumers to come up with strategies on how to manage our health interactions. So the bingo is a really useful one. I'd throw in a couple from a consumer perspective. Deterioration, that usually gets action. Do you have a clinical review committee here that also focuses of attention? But we can talk about that later. Teach back is a technique that is often used for in communication to teach students to say something to them, get the patient to talk back to you, and so that you know that they understand. I think it's actually the wrong way around. We need teach back so that we have told the clinician our story, and then they need to tell it back to us to demonstrate they understand what we need. And that might circumvent some of the scripting that you get to. The other is we talk to patients about, and consumers, carers, about the Ask Me 3 questions and Choosing Wisely health literacy questions, about how to structure your appointment. I think we need to do that with clinicians too, that they understand that when we come in, it's actually about what's our issue, what can we do about it, what happens if we don't do that. And so the scripting that we work with on consumers on how to manage your appointment really well, we could get the communication in that medical, nursing, allied health, education as well.
Hi, so I'm Rebekah Ogilvie. I'm a nurse practitioner with Canberra Health Services, but it's nurse of the year for various things, but anyway. Look, I think that it's a really challenging space for everyone, and even for me as a nurse, sitting in a health workforce that does have a history of hierarchical professional dominance. Often the stuff that we are trying to navigate in our profession is the same things that consumers are trying to navigate also. I think that whole modelling of behaviours is an important one, and certainly from my perspective, you know, I think that I personally pride myself on being the person who says I actually don't know. I think that we do try to, I think that from a curriculum perspective, from a nursing curriculum perspective, we're really trying to change that narrative and be focused on teaching students to say that it is okay to say you don't know, because all you need is, there's always caveats around things. I think often healthcare professionals, like you say, are scared to say that they don't know because they lose face or whatever it is, but in actual fact, what that question does or that statement does is that it forces an interaction that says, let's find this out together. I know a person that I might go to seek help around this, or it forces communication. So I think that, you know, I think the other thing that probably plays into that, into the space from a health professional's perspective is this time, there's constant time pressure. And I think there's an underappreciation from clinicians often when we feel like we're in this, you know, constant, you know, mouse wheel of, you know, of time and constant push through of people from A to B and this kind of interactional way of being, that you forget that the little bit of extra time that you spend on a consultation that might then blow out a time period today actually prevents the long-term investment, because if you added up all of the time points that you end up having somebody coming back asking the same questions, not getting the same nondescript answer, and this, you know, constant churn of processing, that maybe we need to start thinking about the way we structure our healthcare around allowing a longer interaction in the first place to then have those preventative measures. And that's where I think the policy aspect and the way we structure healthcare in general needs to shift.
Before I go to my other question, I just want to add something to that as well. So I have established at the ICH, at the Institute for Communication Healthcare, a consumer reference book to start to address some of these things. I just wanted to echo something that Beck just said, because the same issues that healthcare runs into, academics run into as well. You think about the time that it takes to write grant applications and often what the cycles are like. If you really want to have consultations with consumers that are involved, you need to start early. When the grant comes out, it's usually already too late, especially if you want really sort of consumer leadership in your research applications. So the timing is a resource that we all are very poor on, but the same applies. If you spend a little bit more time up front, you'll reap the rewards later. And as well as you said, if you admit that you don't know, I think academics might be a bit better at that. I'm at least, I always tell my students, I don't know, but I will find out. But there is this point where teamwork comes into play. So you have your colleagues who are also academics that can bring different perspectives, so working interdisciplinary. But if you make the step of making consumers, patient advocates, service users, your co-researchers, they become part of your team. They're not just an add-on, they're not just a participant that you sort of mine for information. You actually want their input in design and in analysis, in interpretation, in dissemination, and in implementation. That is where the real change happens. That's my bit, and I think there was a comment, Joanne. And thanks, Mary.
This is a comment from Brooke Longmain online. Thank you, Jen Norris, for your eloquent, powerful indictment. Clinicians who don't listen, whose egos get in the way of being caring, who can't say, I don't know. I hope that you are teaching in clinical training settings to help learners avoid this in their careers. Did you
I am.
want to comment on that?
Actually, yeah, just,
I am, and thank you for those lovely words to the commenter. I think, you know, one observation I would make about that is, and I'm happy to name the program because I know they wouldn't mind, down, I live in Melbourne, and Monash University alongside Deakin University and Eastern Health Clinical School have a both a simulated patient program, which I do where I bring people other than me, but then they also have a patient communication training program where people actually are just ourselves, you know, and the students practice their communication skills on us with our actual histories. And when I approached them, they said to me, "Are you sure you want to do it? You're 30 years younger than our next person," because it's voluntary. Most of the people are both older than me and retired, but also have, I guess, more common conditions. And they said, "You know, are you sure?" Actually, that's exactly why, you know, I want to do it, because I want to get them early, and we are knowingly putting them in a situation where I 100% do not expect them to know my condition at all. That is fine, but I'm putting them in a situation they don't always come in, because they're used to getting conditions they know about and watching how they respond to that, and then it becomes a teaching moment. And some of them do spectacular, but it becomes a real teaching moment. So actually, I'm very deliberately doing that and deliberately putting those students in that situation in a safe space where they can't offend me. You know, after 20 years of that nonsense, I'm fine to practice it on me rather than, you know, on someone who's in a really difficult situation. So I am, and if anyone else is interested, I'm available for more.
All right, there was another question here.
My interest is in digital health. Like I've got I go to Sydney for treatment, I take my phone with me, I've got my medical records for my imaging, or as much as I can on it, my health record and my digital health record now here. And you know, last week I ended up in an emergency, and I've got all my taken by ambulance, and thought they had my medical pills things with me, and they didn't. But I had it all on my phone, but the ED couldn't access it on their computer. And you know, I go to my GP and said, you know, what are you here for today? And madly types on the computer. I know while she's typing, I can say anything, and you know, nothing happens. So you know, there's a bit of upskilling, not like I'm an older person and I'm assumed, you know, most people assume older people aren't up to date with technology, but a lot of us are, and especially over COVID. You know, my practice where I go to has only just started doing video conferencing for telehealth, and you know, this is 3 years late. Like, you know, that yet we're expected to you know, to have it, and it's great, but there's an imbalance.
So do we have any digital health researchers in the room or online? We have a bunch of research questions right there. Have consumers been involved in designing digital records? Have clinicians been trained in accepting them? Do they know what the different works are? I might hand that over again, maybe start with Beck. Just from your experiences about sort of what the broader issues might be around accessing health information for consumers and how consumers might be involved there.
Yes. From a digital health record perspective, it really, my feeling would be it's very much around, I think organisations will implement a digital health record or an electronic medical record, but they are disparate across the whole, across the nation and between states. And there are issues around privacy in relation to laws between states, which again, I don't necessarily understand. I know. I think that, again, I'm gonna default to the hierarchy of healthcare in the way of clinicians often see themselves as being gatekeepers to meds. So we have this feeling that we need to, like, I'll take it from a nurse because I can only give my lived experience as a nurse. I'm not another healthcare care profession, but we tend to, as nurses, be this, see ourselves as being the patient advocate. So therefore we are the representative. If we're going to take a consumer voice, we're going to be the ones that pushes it towards medicine and says, you need to be, this is, I'm advocating from a patient, no, you're not discharging them, or no, they're not going to do that. Or it's in the background saying to the patient, hey, maybe next time on the round, you might do this thing. And I think, but then at the same time, we have this kind of disconnect around the requirements of our professional practice against the regulation authority. So around, you know, sharing of medical information and those things. So we even find ourselves, so recently I worked in the COVID space in a team which was called the Reach team, but we worked in conjunction. It was Canberra Health Services working in conjunction with non-government organisations and peer groups in vulnerable populations across the ACT, and it was one of the greatest opportunities, I think, that I saw to really think about how we provide services to people that is collaborative and engaging. But one of the things that was really, really like confronting in a way to me was this idea that within my clinical team, which I was the lead of, there was this real reluctance to share information about clients or consumers that we were assisting in that space with non-government organisations. Because of this idea of, well, they're not a clinician, so therefore I'm sharing information, and that's I can get reported to APRA for that, or I can't share this information with a consumer, even though it's their medical, you know, their condition that you're treating and you're supporting. And it's really trying to, so I spent a lot of time just reframing to say, even if that's the case, you've got a non-government organisation that's being contracted by the government to provide clinical care in this context. So therefore the authority is being given to you to be able to do this, but often we have to spell those things out to people. And that's where I think we're probably missing a link in the digital health record aspect, is that we've set up these structures, but we haven't really thought about, well, what does that, we get so focused on the actual implementing of the thing and then the workflow that's attached to that to make sure that we can actually do the things that we're doing, that again, that whole soft skill or idea, it's the same kind of thing. It's just, it's assumed, you know, thing that will catch up, that and that clinicians will just automatically know that this is okay, this is how we do things. So again, I think it's just us trying to, we tend to end up always defaulting to, well, what's the first thing that we need to do, and that's making sure that we can provide care, and then all of this soft skill stuff comes to tail in the background. And I would suggest that your experience with digital health record and my health record is that it's probably just not married up yet, and we're trying to catch up.
I have more information.
And I think the other thing is that, you know, there's a principle that consumers talk about, is that we want the information to follow us. We don't want to be, every single time we go to a different service, have to interact with someone else's system. You know, the whole promise of my health record, you know, $14 billion ago, was that it was no development of that. And it hasn't. One of the things we wanted was one true medication record, and we still don't have it. So there's lots to do. The other thing around digital health, this morning I met with colleagues at Agenda, which is a trans community organisation, intersex community organisation in the ACT, amazing organisation. They were talking with me about some of the challenges they have with the My Digital Health Record that has been introduced in the ACT around dead naming and not using appropriate pronouns. So we're going to go and follow up tomorrow. I've committed to, let's do something about that. We knew that that was potentially an issue. And when we were designing the system with the ACT government services, we had it on the list of something that had to deliver every single time. And it seems like it's not, so therefore it's something we need to do. So the principle of the information has to follow consumers through our journey. We absolutely are committed to that. And the other is we have to have information that we have some sort of control over, and not divert to something that might be on a Medicare record that's outdated or pulling from some anachronistic data source.
Thanks, Darlene. Just to add to what Darlene said too, and just to be really clear, what I'm about to say is my personal view, because I know a lot of consumers don't share it, so just put that out there. But to add to Darlene's, perspective about the control over, patient or community consumer control over records, I'm very pro consensual sharing of accurate information, and I'm going to emphasize accurate there. Because, when my health record came along, people said to me as a person with complex health things, oh, you must be really excited about it, great. I said, I opted out so damn quickly, I can't even explain. And people wanted to know why, right? And nothing to do with all the other problems it had. When you're a person like me, and there are literally millions of us, and you may be one of them and not even know it, who has harmful misinformation on your health record, the thought of that following you out of your control forever is terrifying, right? Like 98% of people with Ehlers-Danlos syndrome have, incorrect psychiatric misdiagnosis on their record because that's what happened to us first, right? And I've got that, it's out there somewhere, but it's from 2004 on some paper document somewhere. But one of the other reasons I'm alive is I was able to escape that, right? I worry for people, growing up through that now who won't be able to escape it. So I'm all for the system existing, but we need controls around correction of not only factual errors, like that's not my address, but about really bad judgment. People often say, well, it's clinical judgment, they can put what they want, but there's gender bias in there, there's racist bias, there's all kinds, you wouldn't believe the stuff I read, in people's health record. And being able to either hide it, correct it, that kind of thing, in a much stronger way than my health record allows at the moment is really important. Because if you look at the research, 17 to 30% of individual items in a health record, not the whole thing, just the individual items, have factual errors in them. So it becomes a rubbish in, rubbish out scenario. We're taking the rubbish and just spreading it further. So we need to address the accuracy issue before we get way too carried away with, the sharing. But as I said, that's a personal perspective from experience and from our research.
I just wanted to flag, I know we're running over time as our session was originally scheduled, but I hope you'll bear with us for another 10 or 15 minutes, if that's okay. To add to that and picking up on something that Nero has said before as well, is like, if you think about consumers being involved, it's not just about health literacy that we've heard about today, it's also about digital literacy. And in a sense, it's also about a thing that I'm just going to call research literacy right now. Because if you think about it, or the academics in a room, or people that are clinicians and academics at the same time, we've sort of been slowly introduced, we know what terms mean, we have sort of grown, socialized into this environment. A lot of consumers are new to this, and if you're a chronic patient, sort of you learn what to say. In research, oftentimes there's all these nefarious terms and no one has any idea what they mean, and no one really explains them to you, and you're trying to figure out what they are sort of by how you learn other terms when you grow up. But it can be a real big barrier for consumers to actually participate, especially as it relates to, I don't have any research skills. My experience is not really worthwhile. Like, why would they listen to me? And I think this is one of the big barriers in terms of engagement that we need to break down, is to really figure out how to make consumers, patient advocate service users understand that their lived experiences is actually what will drive and change perspectives of what academics or clinicians can bring to a research problem. I think there was a question online, and there's 2 more questions in the room, so I'm starting with the online question.
Okay. So this is from Lara, who's attending online, who wanted to thank everyone for their inspiring presentations and consumer advocacy, and especially Jen for sharing their story and bingo. She's asking if you have a cheat sheet or tips for consumers still facing this kind of gaslighting, which has possible life-threatening or quality of life-threatening consequences, especially for those families or consumers who don't have the language, whether English or health literacy, who do have the language as you did, but it's still ignored. And then the second part is, do you think that COVID era effects on public health workforce crisis, due to these, it's getting worse as consumers and providers, clinicians are under more pressure than ever?
Logistics chats then.
Thank you to the questioner again for the kind words and for the question. I'll address the first part first. I don't have a stock standard sheet because there's like 130 items of my records. I had a long time to put that thing together. But you know, when I talk to people, because I do get individually contacted by people going through experiences like that, you know, I usually ask them a bit more about the nature of it and try and kind of narrow down some of the things to look for. But sitting over the top of the more specific things, you know, I always say to people, if your gut is telling you, you know, something's wrong in the sort of more diagnostic sense, like you must listen to that with all of your might. And if you think you're being gaslit, there's a fairly solid chance you are, and you need to act as though your life depends on it, because it may well. And if it doesn't, the worst that happens is you're a bit wrong, you know. And to my earlier thesis, that's okay. And so, you know, what I tell people is, you know, there are some people that believe you should try and convert the practitioner that you are working with, like try and work with them and try and point stuff out. Some people think, you know, just dump and run. I don't have the evidence empirically as to which one of those works better. So what I'm about to say is entirely just on my experience, but I have found dump and run to be a much better strategy. People are hard to change in terms of attitude. And also, if they have a legitimate knowledge gap, like, and that's not their fault, we all have knowledge gaps, but if they have that, they can't magically fill it, right? Like, none of the people were ever going to diagnose me with EDS because they literally didn't know it existed. And so, you know, what I say to people is, if the red flags feel like red flags to you, and yours will be individual, because again, 130, you know, applies in different circumstances, you can try and call it out, and I call it out quite, like, not aggressively, but quite bluntly. You know, I'll say that, like, can you explain to me? That's my favorite beginning of a sentence. Can you explain to me? So, can you explain to me your reasoning for that decision? Can you explain to me why you're sending me to this test or not sending me to this test? Can you explain to me? Because once you make people articulate out loud, if they're going to ever be of any use to you, they've got enough insight as they get half a sentence in to go, now that I'm saying it, you know, this doesn't make sense. So try the, can you explain to me, or can you explain further, or, you know, that kind of thing. If that works, great. If it doesn't, they've probably not got enough insight, personal insight into their thinking, their cognition, their reasoning to ever be of any use to you. And that's when you've got to move on. And I'm not pro just going nuts on the internet in terms of where you might find information, but sometimes you do actually have to go to the crowdsource to find people's opinions on who they have had good experiences with. What's a good doctor is not going to be the same for everybody, but like, it's better to start with someone thought was useful to them than just like out of the white pages, so to speak. But you know, I obviously not knowing the specific circumstances, I hope that's some useful thoughts. Darlene, did you want to add anything?
Yeah, I'll just jump onto that second part of the question about is it harder now? Yeah, I see a lot of exhausted people who have been under sustained pressure, consumers, carers, hospital administrators, researchers, medicos, nursing staff, allied health, all the administration staff that keep things running. Everyone is incredibly weary. What has made it worse? Yes, COVID hasn't been helpful, let's face it. But our broken primary care funding system hasn't helped either. So we've got a bigger, I think, you know, people like Beck are really living the reality of a broken primary care system. And if we had a little bit more focus on that to get it right, then we would be seeing quite the transfer of people to our under pressure acute services.
I'll just do a little ad because I know I'm off a bit. I think that, you know, from the COVID perspective, like Darlene said, you know, yes, it brought things to the, you know, it exacerbated things, and it's very much in your face, and we are exhausted. But at the same time, things exist, you know, it just brought things to the fore. Things existed previously to that. What I do think though is that with every pandemic, there's always following that you end up, there's this impetus for change that occurs. And so for me, I actually feel invigorated by COVID, because I actually do truly believe that we are in a situation where we did things during the pandemic from a healthcare perspective, where I feel like we were more engaged. I feel like we thought outside the box, and we see now that the on-flow effect moving forward, particularly from a workforce perspective, we're not going to suddenly produce graduates tomorrow that are going to fill the gap that exists because of the attrition related to COVID. So we can't function the way that we are without thinking differently and moving and really thinking about how we deliver services. So to me, this is our time. This is for everyone. This is the time for us to be really thinking, how can we change the way that we do things to make this different? And it might be just as simple as having more case management where you are actually having somebody as your person, for a consumer to have a person that is their one source of truth that allows this navigation through a system. Maybe it's as simple as that, but we need to be thinking about how we set services up to be able to facilitate that.
COVID changes for us were pretty, COVID's bad, but, for our consumer group, it was really good because it meant we set it up completely online. Instead of just being localized, it's now across the country because we're running projects across the country. It allows us to train and build capacity across the country, which is something that, to be quite honest, I probably wouldn't have done pre-COVID, because I probably would have thought it's too hard to set up. In the interest of time, and I'm going by this clock, and I want to sort of finish in 5 minutes, I'm just going to take one last question. If the other question, I'm sorry for the people that I can't get to, but we're all around for drinks, so come and chat with us then.
Thanks. It's not really a question, but more a comment and more like from a linguistic lens. I think this panel is really just provides renewed impetus for interdisciplinary collaborative research. And I think so much of what we discussed here is mediated by language, and somehow it's all popped into existence. Somehow we just talked into believing that advocating for patients is responsibility only taken up by nurses somehow, and somehow all these pain is talking into existence. So how do we change that? And I think linguists can really play a role here by looking at how we use language to create all this narrative around somehow hospitals are, sometimes become so normative in terms of being under-resourced, and it's always so fast-paced. So how did that become reality? So yes, I think it is it's quite sobering for researchers, and I think there needs to be more collaboration between researchers and clinicians and pharmaceutical advocates.
I'm gonna rephrase the comment into a question. What do you think the big barriers are to make it work? To make consumer involvement work better than it currently does? Starting with Darlene.
There's a thesis question for you.
This is about how do you improve the system? How do you improve the processes? And you improve it by, number one, wanting or recognizing it needs to be improved and being open to those improvements, recognizing sometimes you're going to hear things that are quite challenging, that you struggle to work through, but it's those principles of collaboration, of inclusiveness, of partnership that will get us there.
All right, then, if you join me to thank this fabulous panel.